to expert level. So you can test yourself using all the standard multiple choice questions. You can use the code as mentioned below for the first live class. There are subscription plans. We have basic, standard, and mentorship program. Mentorship is a wholesome program which is offered at a special discount rate of 50,000. So here, other than the pre-recorded classes, live class, live doubt clarification, we also have one-to-one personalized guidance, as well as we give you the notes. So you can use the code for the subscription. You can as well book a slot for personalized counseling session too, using the code. And about internal exam marathon classes, which we have started since April 22nd. It is for a duration of 45 days. So here we offer you rapid revision of all important questions, volatile facts, quick revision of these all volatile facts, as well as multiple choice questions based on these topics, various topics. And this is beneficial for everyone, all the university exams, because we are compiling all the exam papers and the most important questions there. So we assure top-notch grades in the exams when you take these marathon classes. So you can use the code Dr. Divya 20 for the first free live class too. So we shall begin with today's series. So today's questions, we'll be dealing with the small intestine, large intestine, celiac trunk, superior and inferior mesenteric arteries, portal vein, and border cable anastomosis. So small intestine. So when we say small intestine, we need to define it, location, parts, features, blood supply, lymphatic drainage, nerve supply, and applied aspects. So here we should know that when we say small intestine, all of us know, like it has three parts, the duodenum, the jejunum, and the lower three, this thing. What is that? Ileum, the lower part. So this whole portion, we call it as the small intestine. But when we say small intestine proper, we include only the jejunum and the ileum, because duodenum is, we consider it as retroperitoneal, and we do not include the small duodenum under small intestine proper. So when we say small intestine, it is only about jejunum and ileum, because these two portions of the small intestine, they form the mobile part. So I will be dealing here today with the jejunum and ileum part. So when we say jejunum and ileum, so it begins here. So jejunum begins at the duodenojejunal flexure, and it will extend up to the ileocecal junction. So it is arranged in the coils, okay, series of coils which are suspended from the posterior abdominal wall. So when we see, it is suspended from the posterior abdominal wall by a peritoneal fold, which we call it as mesentery. So this mesentery will be, actually, it will be containing the blood vessels, the lymphatics, lymph nodes, and the nerve plexus, which will be supplying the intestines. Okay. So length of this small intestine proper, when we say, it is about 6 meters or 20 feet. So of which the jejunum is about 8 feet and ileum is the longest, which is about 12 feet. Okay. So, and the special feature of this small intestine is we can remove about 2/5 of the small intestine. If there is a gangrene or if it is disease, we can remove 2/5 of the intestine without any disrupting the function of the intestine or causing any physiological disturbance in the body. So when we see the structure of the intestine, so basically when we see inside of it, it is consisting of mucosal folds, and histology we study that it has 4 layers. That is the mucosal layer, the submucosal layer, the muscularis layer, external layer, and the serosa layer. So here you can see the mucosa is thrown into many folds, and there are projections which we call it as the villi. So all these things, they will help in the absorption. Okay, absorption. So these folds, we call them as the plica. And then we have below that the supporting tissue, that is the submucosa is present there. Okay, this is the submucosa. So mucosa will consist of this lining epithelium, which consists of the columnar epithelium. Okay, the below the lamina propria, as well as the muscularis mucosa layer, which consists of circular layer of smooth muscle. So why all these things are important is This muscularis mucosae contractions will help in the movement as well as it helps in this squeezing action of this glands and the lacteals there. Then we have the submucosa. So here it has the mucinous nerve plexus are present and two layers of muscles. That is the inner, that is longitudinal and circular and longitudinal layer of muscles are arranged. Okay, so these muscles, that is in between those two layers of the muscles, we have the nerve plexus, which are known as Orbach's nerve plexus. And outside, there is the peritoneal covering, that is the visceral peritoneum is covering that, and that we call it as the serosa layer. So that is the structure. So to the naked eye, we always also see in the small intestine, okay, that is in the ileum, okay, aggregation of lymphatic follicles. So aggregation of these lymphatic follicles, we call it as the Peyer's patches. So these are the things we see. So we will go for the differences between those two. So before that, here, if you see the blood supply here, it is through the branches of the, that is the jejunal and ileal branches of the superior mesenteric artery. So if you closely observe here, okay, so these arteries, that is the jejunal and the ileal branches, they form arcades. Okay, so they loop around here and they are forming the arcades. So if you see near the jejunum, they form less number of arcades, one or two. As we move towards the ileum, the number of arcades are more, arterial arcades. And from these arterial arcades, straight arteries arise, which we call it as the, that is this is the vasa recti. Okay, so the straight arteries, we call them as the vasa. Vasa means blood vessel. Vasa recti, recti meaning straight. So here we see, because there are less number of arcades, we see longer vasa recti, whereas towards the ileum, we see shorter vasa recti. Okay, so shorter vasa recti, more number of arterial arcades is towards the ileum. Jejunum, less. So that is one of the differences. The lymphatic drainage, mainly it is into the superior. So the mesenteric, within the mesentery, there are mesenteric group of lymph nodes, and from there they go to the superior mesenteric group of lymph nodes. So that will be the main group. So the nerve supply of jejunum and ileum. So it has got both sympathetic and the parasympathetic nerve supply. Okay, so okay. So here when we see, it is through the splanchnic nerves. Okay, so the splanchnic nerves through the superior mesenteric ganglion. So the superior mesenteric ganglion, here the splanchnic nerves come, and from this they supply. Okay, so the postganglionic fibers, this is for the sympathetic. It is coming from the thoracic, whatever this thing, nerve plexus. Okay, so nerve plexus, it comes. So we have the splanchnic nerves, which form splanchnic nerves, and from this they relay the superior mesenteric ganglion, and from there begins the postganglionic fiber nerves, fibers which supply the small intestine. Okay, so the parasympathetic is through the vagus. So the vagus nerve supplies the parasympathetic nerve supply to the large intestine, small intestine. So now coming to the differences. So the differences between the two types, that is the jejunum and the ileum, is very important. Okay, so if we see from outside, okay, so the lumen here, it is wider, whereas this is narrower compared to the jejunum. It has a thick wall, whereas this wall is thin. Okay, and within the inside, that is the interior of the jejunum, we will see larger and closely placed circular folds and solitary nodules here and there. Here, the circular folds are shorter and they are sparse. Compared to the jejunum, they are less here. Okay, and here we see aggregation of lymphatic nodules or the lymphatic follicles, which we call it as the Peyer's patches. And this is in the jejunum and the ileum, the luminal differences. Whereas in the mesentery, we will see, I already told you that we will have 1 or 2 rows of arterial arcades. Here we will have 4 to 5 rows of arterial arcades. Here we have straight and long vasa recti. Here we have short vasa recti. Then between, in the mesentery, there is always also the amount of fat. So when we try to just spread that mesentery, and when we see here, what happens is there is less amount of fat between these vasa recti. Whatever the peritoneum will be present, the mesentery will be present, the fat will be less and it will look transparent. Whereas here the fat will be more and it looks opaque. Okay, so those windows, we call them as the peritoneal windows between two vasa recti. The mesentery which is present is known as the peritoneal window. So here the peritoneal windows are transparent. Here the peritoneal windows are opaque. So these are the differences you should know between jejunum and ileum. So here one of the common and among the applied aspects, what you have to write is about Meckel's diverticulum, which is a very common condition which we see here. So what is this Meckel's diverticulum? So if you see here, it is a blind pouch which arises from the anti-mesenteric border, means the border which is where the mesentery is not attached. Okay, so from the anti-mesenteric border it arises. So here this Meckel's diverticulum, it observes rule of 2. Okay, rule of 2. So that means it is about 2. Okay, it lies about 2 feet from the ileo. This is the ileocecal junction. So it is about 2 feet proximal to the ileocecal junction. It is present in about 2% of the population and it is about 2 inches long. Okay, 2 inches long. So that is the rule of 2. Okay, about 2 feet from the ileocecal junction. That is its common location. It is about 2 inches long and it is seen in about 2% of the population. Okay, so what is this Meckel's diverticulum? It is a remnant of the proximal part of the vitellointestinal duct. Okay, so this portion, small intestine, it is derived from the midgut. Okay, so midgut during the time of development, it would be attached there, okay, to the outside yolk sac. It will be communicating, okay, through this vitellointestinal duct. So once the small intestine is developed and it is taken in, okay, that midgut development happens, it's taken in. Usually the vitellointestinal duct will obliterate. But sometimes if it doesn't obliterate and the small portion remains patent, it results in the formation of this Meckel's diverticulum. Okay. So here, what is the complications or things which we see is, one is peptic ulceration is very common in this Meckel's diverticulum. And sometimes it can lead to perforation. Okay, and then this diverticulum can also be inflamed. Okay, it can be inflamed, and that will lead to peritoneal. The infection may spread to the peritoneal cavity, and sometimes a small loop of the small intestine will encircle. Okay, it might go around this Meckel's diverticulum, and it may lead to obstruction, intestinal obstruction. So these are the things which happens because of the Meckel's diverticulum. Okay, so when we talk about small intestine, we have to know what do we mean by small intestine proper. So basically small intestine proper is asked. Duodenum is asked along with the, that is pancreas. It is, and because it is fixed. This small intestine proper, when we say, it is the mobile part of the small intestine, which includes jejunum and the ileum. Okay, jejunum and ileum. So you should know the differences between jejunum and ileum. Okay, so the differences between their surfaces, interior structure. Okay, so differences between jejunum and ileum, you have to write those differences. Then you have to write the blood supply of it, which is important. Then nerve supply and lymphatic drainage. Then you write about the applied aspects, which is most important. And Meckel's diverticulum, it itself is asked as a short answer question. Applied aspects, mainly you talk about Meckel's diverticulum. Okay, so these differences can be also asked as MCQ questions. Okay, MCQ questions where Peyer's patches is seen in which part, or it can be asked some of the features may be mentioned and all of these features are seen in the jejunum, or all of these features are seen in the ileum except, so things can be asked like that. Okay, so and Meckel's diverticulum also. Okay, so the remnant of vitellointestinal duct is known as, or Meckel's diverticulum is, they will give some choices where you have to identify, or the features of Meckel's diverticulum include all, like seen that observes that 2% rule. It's a remnant of that, causes peptic ulcer, causes intestinal obstruction. So like the choices can be given. So you need to know about it. Right. So these are the summarized things which you have to, under which headings you need to explain the small intestine proper. Then we go to large intestine. So large intestine, when we say, okay, so where does the large intestine begins? So large intestine portion, it includes the portion from the ileocecal junction up to the mucocutaneous junction here of the anal canal. That is up to the pectinate line, mucocutaneous junction of anal canal. So that portion till there, we call it as the large intestine. So when we say large intestine, it includes the appendix, okay, the cecum, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, the rectum, and the upper part of the anal canal. So this much portion is large intestine, okay. So here, when we say, questions can be asked separately about appendix, about cecum, okay, and large intestine mainly like colon can be asked, because this portion we call it as the colon. So colon up to descending colon, sigmoid colon can be asked, okay. So I'll be just telling the features, because features of large intestine is asked as a 3-mark question, and appendix and cecum can be separately asked as a short essay questions. So we'll deal with these two and then we go to the colon. Okay, so generally the large intestine will have 3 cardinal features. To say, so call it a large intestine, it should have about these 3 features, that is tinea coli, appendices epiploicae, and saculations or rostrations. Okay, so tinea coli is basically the thickening. In 3 portions, we see the thickening of the tinea coli, that is a longitudinal layer of the smooth muscle, which forms thickening in 3 parts. So that is known as the tinea coli. Okay, so we see tinea 3 portions. Okay, so when I talk about colon, I will tell you. And here we have appendices epiploicae, that is peritoneal pouches filled with fat, is known as appendices epiploicae. And then we have saculations, that is the folding of the colon, okay, the large intestine. So here what happens is, because the length of the large intestine, it is about 1.5 meters or so about 6 feet, okay, in length. So to accommodate it between these tinea coli, what happens is, it is thrown into folds like scalloping, like in the curtains, we see the scalloping, right? So that way, we'll see the scalloping, which we call it as the saculations or rostrations. Okay, so first we will deal with the cecum and then go to the large intestine. Okay, so cecum, when we say, what is the cecum? So cecum is the beginning of this large intestine. Okay, so this has all the features of the large intestine, whatever I said earlier. So it has features. So size, it is about, so here if you see, the breadth is, so one of the organ, like, you know, we have different organs like the prostate gland, the pituitary gland, okay, where the breadth is more than the length. So here also in the cecum, the breadth is about 7.5 centimeters, whereas the length is about 6 centimeters. Okay, and it lies in the right iliac fossa. The shape, it is usually asymmetrical cul-de-sac. Cul-de-sac means one of the end is blind here. Okay, this end will be blind. So when it ends blindly, we call it as the cul-de-sac. So it is asymmetrical. Okay, so here in the interior we see three. Okay, so we will see features here. One is the ileocecal orifice. Okay, this is the ileocecal where the ileum opens into the cecum. So this is situated in the posterior-medial wall of the cecum at the junction of the where the cecum joins with the ascending colon. This is the ascending colon part. So at that junction, we will see this. Okay. So this orifice is guarded by a valve. Okay, it has a valve which consists of an upper lip and a lower lip. So upper lip, you see here, it is more of horizontal, whereas the lower lip is concave. So these valves will be guarding the, what is that? The ileocecal orifice. Whereas there is one more opening which we see, which is called as the appendicular orifice. Okay, appendicular orifice, where the appendix cecum leads to the appendix here. So it is a small circular opening. It is about 2 centimeters below and slightly behind the ileocecal orifice. Okay, so it will be lying about 2 centimeters below that. So this also is guarded by a valve, which is a semicircular. Okay, which is semicircular, and that valve is known as valve of Gerlach. Okay, GER, Gerlach. So that valve we call it as the, here we see the valve. Okay, that valve is known as the valve of Gerlach. So that will be attached to the lower margin there. So based on the shape, we have different shapes of the cecum. Okay. So what usually at the time of birth, we see cecum like this. This is the fetal type. Sometimes this type, it remains in adult life too. So that time we call it as the fetal type or conical type. Okay, conical type 1. So about 2% of the population, we see this fetal type of cecum. So here, if you see, appendix will be arising from its apex straight like this. Appendix is present here. Then the next shape we have is the infantile type. Okay, or the quadrate type. We say infantile type or the quadrate type, which is type 2. So this we see in about 3% of the population. Okay, so here if you see the right and the left saccules, they are of equal size. Okay, so that is called as the infantile. And infantile, it will have, the appendix will be present near the depressed part of the sacculus here at the bottom. Then we have the third type, that is normal or adult type, we say. So this we see in about 90% of the population. So here what happens, if you see, the right saccule is enlarged, okay, whereas the left saccule is small. So the appendix will be, so at this level what happens, because of that, this has grown more. This appendix would have been shifted this side and it will lie about 2 centimeters below the, okay, 2 centimeters below the ileocecal junction. So here we have the appendix. So this is normal type. So this is the commonest type of cecum which we see in the population, about 90% we see. Then we have the fourth type, that is exaggerated type, where the right cecal pouch is very large. Okay. So here we see it, so right is very large, whereas left is almost not there. Okay. So only the right side we see. So the appendix will be shifted closer to the ileocecal junction. So this we see in about 4 to 5% of the population. Okay, 4 to 5% of the population we see. So normally the cecum, it will lie in the right iliac fossa. Okay, it will be lying in the right iliac fossa. And the peritoneum. The peritoneum will be covering the cecum. Okay, so on all sides, on all the sides, as a rule, the peritoneum will cover. So only in about 5% cases, we don't see in the upper part of its posterior surface, we don't see it, okay, because see, the cecum will continue as the ascending colon, and ascending colon posterior part is not covered by the peritoneum, right? So what happens is in some 5%, because the cecum little bit extends upwards, that portion, upper part of the posterior surface will not be covered by the peritoneum. But generally, we say it is covered by the peritoneum on all sides. Okay, so so within this peritoneum, we will see the artery and vessel. So you can see here the anterior cecal artery. Okay, so it will be reaching the anterior and posterior. So basically, what happens is the inferior division of ileocholic artery. Okay, ileocholic artery divides into anterior and posterior. So this is the anterior cecal, and we have behind we'll have the posterior cecal. Okay, so they supply the blood supply to the cecum. Venous drainage is into the ileocholic vein. Okay, and after that it goes to the superior mesenteric vein. Lymphatic drainage occurs into the ileocholic group of lymph nodes. Now supply is derived from the superior mesenteric plexus. Okay, that is the preganglionic fibers. They come from P10 to L1 part. The parasympathetic fibers are derived from the vagus here. Okay. So these are the things which we should know. And among the relations, now when we see the relations, visceral relations, posteriorly, the cecum is related to the right gonadal vessels. Okay, this is the psoas major muscle, so right gonadal vessels. So this dotted line is the cecum. So here we see the right gonadal vessels, then the psoas major muscle here, then we have the genitofemoral nerve, the lateral cutaneous nerve of thigh, the psoas major, the iliacus, okay, the external iliac artery, and the femoral nerve. So these are the structures which lie in relation to the cecum, okay, posterior to the cecum. So all these things are important, especially when we are doing a surgery in that region. So interior, I already explained to you. This is the opening which is guarded by the valves. Okay, so this is upper lip is horizontal, whereas this is concave. This is the valve of Gerlach guarding the orifice of the appendix. Okay, so blood supply. This is the anterior cecal, already I told you. So it divides into, okay, and this is the ileocolic, inferior division of ileocolic, dividing into posterior cecal and the anterior cecal. Okay. So next we move on to the appendix, okay, which is otherwise called as the vermiform appendix. So it is a narrow, why it is called appendix is because it is like a worm-like, okay, worm-like. So that is why it is called as vermiform appendix. So it is a worm-like tubular diverticulum which arises from the posterior medial valve of the cecum. So your hand lies about 2 centimeters below the ileocecal junction. Okay, so it is suspended by a peritoneal fold, which we call it as the mesoappendix. Okay. So this, so when we mark this appendix, surface anatomy of this appendix is commonly asked. Okay, like in MCQ also it can be asked. It can be asked as a short answer question. So here, how we do is we draw the transtubercular plane, which passes through the 2 tubercles of the iliac crest. We draw the right and left lateral planes, that is otherwise called as the midclavicular lines. Okay, we extend it downwards. It is known as the lateral planes. So at the junction of this right lateral plane and the transtubercular plane, we have the McBurney's point. So McBurney's point here at this point actually at this intersection, we will have what we call it as the ileocecal junction, lies at this intersection. Okay. And here only there is this McBurney's point. McBurney's point is the point of maximum tenderness. So what we do from the anterior superior iliac spine to the umbilicus, when we draw a line, okay, the junction of the medial 2/3 and the lateral 1/3 is the McBurney's point. Now here, after this intersection of this light lateral plane and transtubercular plane, so at this junction, we have what we call as the ileocecal junction is present. So about 2 centimeters below from there, we mark a point, and that point is the appendix. So in the appendix, so generally the appendix can measure from 2 centimeters up to 20 centimeters. The average length we call is about 9 centimeters. Okay. So this appendix will have a tip, okay, the body and the base. Okay, mesoappendix by which is suspended and the base. So the base is attached to the posterior medial wall of the cecum, about 2 centimeters from the ileocecal junction. So here, among the features of the, what is that, large intestine, okay. So large intestine, to say it should have tinea coli, it should have appendices epiploicae, as well as it should have the saculations. So those features here are absent. So here actually the tinea, all the 3 tinea, they will converge here near the base of the appendix. Okay, and that will actually serve as a guide to locate the appendix. So important here is the positions of the appendix. Okay, so appendix can be present in different positions. So we akin it to the like a clock. Okay, the clock and different clock positions. Okay, so we have from this, that is the 11 o'clock position, which is otherwise called as the paracolic or subcolic position. Okay, so this is present in about 2%. Okay, so where we have paracolic, which is next to the cecum. It will be lying next to the cecum, paracolic, about 11 o'clock position. Okay, so we see this in about 2% of the patients. Then we have retrocecal. Retrocecal means behind. This is the retrocecal. You can see this, what is that? Tracing of this appendix here, okay, which is because it is behind the cecum. So that is the retrocecal position, which is otherwise known as the 12 o'clock position. So 12 o'clock position, it is the commonest position of the cecum, okay. Then that is about 60% we see. Then we have 2 o'clock position. So 2 o'clock position is here. So this 2 o'clock position can be two types, that is pre-ileal or post-ileal. Okay, so it can lie either in front of the ileum or behind the ileum. So it is known as the pre-ileal and the post-ileal position. So this is present in about 1 to 2% cases. So the pre-ileal variety is the most dangerous, because here what happens, if there is an inflammation from the appendix, it will spread to the entire peritoneal cavity. Okay, so pre-ileal is a very dangerous position. Then we have 3 o'clock position, which is called as the promontory. So it will be pointing towards the sacral promontory. Okay, so this is a very, very rare type of position. Then we have pelvic position, which is about 4%. So this is the second common type. Pelvic is second common type of position, which we see in about 30% of the cases. Okay. And then we have the mid-inguinal or 6 o'clock position. This is also a very rare position. Okay. Mid-inguinal. So mid-inguinal position, it is directed downwards. So this appendix is supplied by the appendicular artery. Okay, appendicular artery, a branch of the inferior division of the ileocolic. Okay, so the same thing which is supplying the cecum will also give an appendicular branch. Okay, so venous drainage is into the superior mesenteric vein. So corresponding artery, corresponding vein, and into the superior mesenteric vein. Lymphatic drainage is into the superior mesenteric group of lymph nodes. So the parasympathetic nerve supply will be by the vagus, okay, and sympathetic is derived from superior mesenteric plexus. Okay, so large intestine or the colon, when we say now, I'll just tell you here the main features are important. That's it. Okay, so the colon as such is about 15 centimeter long, okay, and about 5 centimeters in caliber. So all the way it extends from as a continuation of the cecum, okay, from the transtubercular plane to the right colic flexure, and where it turns to the left and continues as the transverse colon. Okay. So here the three features what we see here, that is the tinea coli. So we have the tinea coli, we have the appendices epiploicae, and these saculations. Okay. So here, these tinea, we have three. One we call it as the tinea libera, other one is the tinea mesocolica, and other one is the tinea aumentalis. Okay, so towards this side will be, this is the tinea libera, this side will be the tinea aumentalis, and this side we will have the tinea mesocolica. Okay, so when it changes the position, here we will see the tinea mesocolica, tinea libera goes downwards. Okay, and we will see the tinea aumentalis on the other surface. So tinea libera will lie in front, tinea mesocolica on the posterior medial surface, and tinea aumentalis will lie on the posterior lateral surface of the ascending column. Okay, so these are the three features which I already told you about earlier. So arterial supply. Here, the colon, the arterial supply is important here when we see. Okay, so here what happens is, if you see the right 2/3 of the transverse colon, okay, right 2/3 of the transverse colon, as well as this ascending colon, okay, is supplied by the right and left, by the branches of the superior mesenteric artery. Whereas the left 1/3 of these transverse colon, the descending colon, the sigmoid colon, they are all supplied by the branches of the inferior mesenteric, because based on their origin, okay, because this is derived from the up to the right 2/3 of the transverse colon, it is derived from the midgut, whereas this is derived from the hindgut. So the portion which is derived from the midgut is supplied by the branches of the superior mesenteric, okay, whereas the rest is supplied by the inferior mesenteric artery. So the right 2/3 of the transverse colon here is supplied by the right and left branches of the middle colic, okay, whereas the left 1/3 of the transverse colon is by the ascending branch of the left colic artery, okay, which is derived from the inferior mesenteric. Here, this side, the ascending colon, here we can see the right colic artery. So here the ascending, so what happens is these branches. So it will give a middle colic and it will give the right colic, ileocolic. So ileocolic, the inferior branch, that is the lower branch, would have been supplying the cecum and the appendix. Whereas this branch here, ascending branch, will anastomose with the descending branch of right colic artery. The ascending branch of right colic will anastomose with the descending branch of middle colic, and they will be giving many arteries which will be supplying the intestine. Okay, so these arteries, what happens is, as you see along here, they will anastomose with each other. Okay, like this, they will be anastomosing with each other, and they form the marginal artery of Drummond. Okay, this marginal artery, this is known as the margin. This anastomosing channel between the branches is known as the marginal artery of Drummond. So from this marginal artery, we have the vasa longa and vasa brevia. That is, which are longer, we call them as the vasa longa. If they are shorter, we call them as the vasa brevia. They arise and they supply the entire gut, that is the large intestine, by dividing into anterior and posterior branches. Okay, so venous drainage is basically into the superior and inferior mesenteric vein, which follows the direction of the blood vessel vein. Okay, it's corresponding arteries. Lymphatic drainage, so from the right 2/3, it will be draining into the superior mesenteric group of lymph nodes, and from the left 1/3 into the inferior mesenteric group of lymph nodes. So within the mesenteric, there will be smaller nodes. These are the paracolic nodes, epicolic nodes, intermediate colic nodes. Okay, so from these, it will ultimately go to the superior and inferior mesenteric group of lymph nodes. Okay, so here nerve supply is for the right 2/3 of the colon. The sympathetic nerves derive from the superior mesenteric plexus, and the parasympathetic is from both vagus. Okay, so for the right 2/3, this side, this portion. Whereas for the left 1/3, this portion, the sympathetic is derived from the superior hypogastric plexus, L1 and L2, and the parasympathetic is from the pelvic splanchnic nerves. Okay, carrying fibers from S2, S3, and S4. So we'll go to the superior mesenteric artery. So superior mesenteric artery, when we see, where does the superior mesenteric artery begin? Superior mesenteric artery is a branch of it is the anterior branch of which one? The abdominal aorta, superior mesenteric artery, right? Okay, so it arises from the front of the aorta. So where does it arise? It arises about 1 centimeter below. Now this is the celiac trunk. These are the anterior branches, celiac trunk, superior and inferior mesenteric. Okay, so arises from about 1 centimeter below the celiac trunk. Okay, opposite the lower border of L1 vertebrae. So at the level of L1 vertebrae, it arises. So at the origin, if you see here, it is overlapped by the body of the pancreas. Okay, so it will be between two structures there, sandwiched between two structures. That is, the splenic vein will be above and the renal vein will be below. So between those two structures, this will emerge. So superior mesenteric artery, it will run downwards, okay, and forwards to the right. Okay, here it goes to the right in front of the uncinate process of the pancreas. Then it crosses the third part of the duodenum. Then along its course, it will cross the inferior vena cava, the right psoas major, the right ureter, and runs along the root of mesentery towards the right iliac fossa. So here it will anastomose with the ileocolic branch, means its own branch. Okay, so it gives an ileocolic branch, and this will end up with the anastomosis with the inferior branch of the idiocolic artery. Okay, so that is its course. So what are the branches it gives? So from this convex side here, left side, it will provide about, this is this side. Okay, so this side, it will provide about 12 to 15 jejunal and ileal branches. Okay, which will be forming the arcades and supplying the jejunum and ileum. Whereas on this side, that is from the concave right side, it will give from above downwards when we come. First, it will give the inferior pancreatico-duodenal artery. Then it gives the middle colic, the right colic, and the ileocolic. And each of these will give these ascending and descending branches, which will be anastomosing with each other, supplying the large intestine. Okay. Then we have inferior mesenteric artery. So where does this inferior mesenteric artery begin? It also begins from the front of the aorta, about 4 centimeters above the bifurcation of the where the abdominal aorta will divide, into the common right and left common ilia. So about 4 centimeters above it begins. Okay. So that is opposite L3 vertebrae. So here it is overlapped. Okay, at this junction, the origin is overlapped by the third part of the duodenum, and the trunk of the artery. Okay, it passes. So if you see here, it passes retroperitoneally downwards along the left side of the aorta, and it will enter the lesser pelvis. Okay, lesser pelvis, it will enter. That is the false pelvis. When we say less, that portion, okay, slowly it enters there and crosses the left. After crossing the left common iliac. So this is the left common iliac. It will enter the lesser pelvis. Okay. So here it will give. So once it goes to the lesser pelvis, the artery will be accompanied by the inferior mesenteric vein on its left side, and it will continue. There it will continue as the superior rectal artery. Okay. Lesser pelvis is the true pelvis. Above that wider part will be the false pelvis or greater pelvis, we say. So on reaching this, so continues as the superior rectal artery. So with this will run along the descending limb of the root of the sigmoid colon. Okay. On reaching the rectosigmoid junction, the superior rectal artery will divide into 2 lateral branches. Okay. So then it will be forming a plexus there, artery plexus. So here this side, it will give, in addition to the superior rectal artery, which is actually a continuation of the inferior mesenteric artery, it will also give left colic. Okay, so here you see this is the left colic artery, and it will also give sigmoidal branches. Okay, so these are the 3 branches of inferior mesenteric artery. So superior and inferior mesenteric vein, these are also follow the same course as of the, but it is towards the draining vein. Okay. So superior mesenteric vein again extends from the right iliac fossa towards the abdominal aorta. That is where what happens here is the superior mesenteric vein. It will go behind this same course, like how it will follow the course of the superior mesenteric artery. So behind the, it passes behind the body of the pancreas and near the neck of the pancreas. Okay, what happens is it is joined by the splenic vein to form the portal vein. Okay, it forms the portal vein. So here it receives, so its tributaries include the inferior pancreatico-duodenal vein, the right gastroepiploic vein, then all this middle colic, right colic, and ileocolic veins, as well as the jejunal and ileal veins. They are the tributaries. This inferior mesenteric vein, now this begins in the lesser pelvis again here. Okay, that is superior rectal vein, continues as inferior mesenteric vein. So this is joined by the sigmoidal veins. Okay, as well as the left colic vein. So named branches of artery, the same similar veins will be there, which will be draining into the main vein. Okay, so this inferior mesenteric vein, instead of joining the superior mesenteric or portal vein, it will join the splenic vein. Okay, it will open into the splenic vein, and splenic vein will join to form superior mesenteric vein from the portal vein. So these are the things which you should know in large intestine. So in the large intestine, when we covered, so you should know the parts of the large intestine. First, from where to where we say large intestine, okay, and its extent, okay, and its parts, which are the parts you should know. You should know about cecum. So cecum, the most important thing which we have to know is the types of cecum, which we see, the features, internal features, which are the valves and features which we have to see there. Okay, internal features we have to see, and we have to know the shapes here. The shape, that is the type based on the shape we said. Then appendix. Okay, appendix you should know. So appendix, you need to know about the positions. Positions is very important. The different positions of the appendix you should need to know. You need to know what is McBurney's point. Okay, it can be asked as a MCQ question too. Okay, and the artery supplying superior mesenteric artery. Okay, as well as the course of inferior mesenteric. Superior mesenteric is very important, where you should know its branches too, and inferior mesenteric artery. Okay, so and corresponding veins which drain the large intestine. So these are the things which we have to know under the large intestine. Okay, so superior mesenteric artery, I already explained to you the course from where to where the course is. Okay, so this is just a revision of it. So it begins about 2 centimeters below the celiac trunk. So usually any artery you should write under origin, termination, course, branches. And if there is an epilioid aspect, you should mention it. So it will be running within the mesentery. Okay, so it passes below, that is, it is overlapped by the body of the pancreas, passes about this uncinate process, crosses the third part of the duodenum, runs within the mesentery. Okay, so the root of the mesentery, till where it extends, it will be running, and it will terminate by anastomosing with the inferior branch of the ileocholic artery in the right iliac fossa. Okay, and it will be giving the inferior pancreaticoduodenal artery, middle cholic, right cholic, and the ileocholic artery. Okay, on the concave side, whereas on the convex side, it will give the jejunal and the ileal branches. Okay, so that is the superior mesenteric. Okay. So coming to portocaval anastomosis. So portocaval anastomosis is one more which is commonly asked question which you need to know. Okay, portocaval anastomosis. So what do we mean by portocaval anastomosis? So what happens is, as the name says, the anastomosis, okay, the anastomosis between the portal system and the tributaries or the veins, okay, which belong to the portal system, and between the tributaries which belong to the venicaval system. Okay, so that is the portal and systemic veins, where the anastomose, we call it as the portocaval anastomosis. So you should know the sites at where these anastomosis is happening, the contributing, which veins are contributing there, and applied aspects. So you can, so this is the different sites here. Okay, so we have it near the Bair area, below the diaphragm, near the Bair area. We have near the cardiac end of the stomach here, that is the esophagus and the junction of the stomach here, cardiac end. Then we have within the peritoneum near the spleen, okay, near the kidney here. Then we have near the rectum, okay, and in the umbilicus. So we will see the sites here where it is and what are the anastomosis. So first site, common site, is the umbilicus. So at the umbilicus, the systemic vein is superior and inferior epigastric veins. So the portal veins which belong to the portal system are paraumbilical veins. So they will anastomose with each other. Okay. So sometimes when there is portal hypertension, okay, these veins will enlarge and it gives an appearance of serpentine veins dilatation around the umbilicus, and that is known as caput medusae. Okay, Medusa is a Greek mythological character where her head was, instead of hair, she had serpents. Okay, or on her head. So that is why, since these veins, when they dilate, they look very tortuous and like very serpentine, it is called as caput medusae. Then the next site is lower end of the esophagus, where the esophageal tributaries of the hemizygous, which belong to systemic system, okay, systemic vein, anastomosis with esophageal tributaries of left gastric vein. So this leads to esophageal varices. Okay, if there is any portal hypertension, there is esophageal varices, otherwise called as esophageal files, and it leads to hematemesis. Just like how hemorrhoids will cause lower end bleeding, this will cause the upper end vomiting of blood, which is known as hematemesis. Then we have anal canal. At the anal canal, it is middle and inferior rectal veins of internal iliac vein, and they will anastomose with superior rectal veins, okay, which belong to the portal system. So if there are an enlargement here, it results in hemorrhoids. So you can see it here at this point, okay. This was what I talked, umbilicus, and we talked about the esophageal varices. Then near the bare area of liver, that is phrenic and intercostal veins, they will anastomose with the hepatic veins. Then posterior abdominal wall, here we see renal, lumbar and phrenic veins. They will be anastomosing with veins draining the retroperitoneal part of the gut. Then we are also see this is before birth, okay, in the falciparum ligament between the diaphragmatic veins and the paraumbilical veins, and in the fissure for ligamentum venosum, that is in the fissure for ligamentum in the liver, again there we have that is inferior vena cava, which will be anastomosing with the left branch of the portal vein. Okay, so these are the different sites which you should know, and you can make these 4 columns and answer. It's always better to answer this question in this pattern. Okay. Okay, so next we move on to the celiac trunk. Okay. So celiac trunk here, it is one of the branches. So again, any arteries we write under origin, termination, course and branches. So celiac trunk, when we mention celiac trunk, no, why we call it as a trunk is because the course is very short of that. Immediately it divides into branches. So it is a short, wide. Okay, so if you see here, it is a very short and wide vessel, just about 1.25 centimeters long, and arises from the front of the aorta, immediately below the aortic opening of the diaphragm, that is at the level of T12, okay, vertebrae. So as soon as it arises, it divides into 3 branches. That is the left gastric artery, the left common hepatic artery, and the splenic artery. Okay, these are the 3 branches of the celiac trunk. So the left gastric artery, it will run along the lesser curvature of the stomach, right, and it anastomoses with the right gastric artery and supplies the stomach there. Okay, so that is the left, it's the smallest branch. The left gastric artery is the smallest branch, but it supplies the stomach mainly. Then the common hepatic artery here, it is larger, okay, than this, and it passes through the right here. So this will divide into 3 branches, that is hepatic artery proper supplying the liver, okay, and we have the gastroduodenal artery, and it will also give the right gastric artery. Okay, gastroduodenal artery will further divide into superior pancreaticoduodenal and right gastroepiploic. The right gastroepiploic again supplies the along the greater curvature of the stomach. Okay, then the splenic artery is very tortuous in its course. Okay, so it will give short gastric arteries supplying the near the fundic area of the stomach. It will also give the great pancreatic artery, arteria pancreatica magna, which supplies the pancreas, as well as it gives the inferior pancreatic artery to supply the pancreas again, and left gastroepiploic artery, which will anastomose with the right gastroepiploic artery and along the greater curvature of the stomach. Okay, so these are the branches of the celiac trunk. So you have to enumerate the or tell about the branches of the celiac trunk. Okay, So those are the things. So any artery where it began, so at the level of T12, okay. So celiac artery, it begins. It is about just 1.25 centimeter in length. Immediately divides into its three branches. Main branches are three. The left gastric, okay, left gastric artery. Then we have which one? The splenic artery, because this is the largest branch, and this is common hepatic artery. Okay. You can further elaborate on these branches. So splenic will give short gastric, then it will give left gastroepiploic. Okay, then it also gives the arteria pancreatica magna, large artery to the pancreas. And superior pancreatic artery it gives. This one common hepatic will give again divide into three, that is proper hepatic. Okay, proper hepatic, then gastroduodenal. Okay, gastroduodenal and right gastric. This we can make like a flow diagram, and again gastroduodenal will give two branches again. The superior pancreatico-duodenal, okay, duodenal, and we have the right gastroepiploic. Okay, so like that. And what area supplies, if you mention, it's enough. Okay. So that's about inferior mesenteric artery. I already explained. Okay, so the origin, termination, course, and branches. So it begins here about 4 centimeters above the bifurcation of the abdominal aorta. Okay, so it runs into the lesser pelvis, where it continues as the superior rectal artery, which again divides into right and left lateral branches. It also gives the left colic artery as well as the sigmoidal arteries. Okay, so your branches, they form an anastomosis with each other, and what we call it as the marginal artery of Drummond is formed, from which the vasa recti begins, and it supplies the structures, that is the colon. Okay. So next question is portal vein. So portal vein here. Okay, so same thing. Any veins, arteries, we follow the same pattern: origin, termination, course, relation, and tributaries. Okay. So what is portal vein now? The portal vein, it drains the blood. Okay, it mainly drains the blood from the abdominal part of the abdominal part. Okay, that is the abdominal part of the alimentary tract. So whatever the structures are there in the abdominal part of the GI tract, belonging to the GI tract, the blood is mainly drained by the portal vein. Okay. So it drains all that part. So again, this question is asked as an MCQ. It drains all except. Okay, so what part it doesn't drain is the rectum and the anal canal. So why this you should understand is the portal vein, basically whatever the blood it drains from the GI tract, it is taking it to the liver, and the liver is the organ which will basically take part in all the metabolism. So what is this vein taking? The vein is taking all the nutrients from the intestines, which is absorbed, okay, which is taken up by these veins and brought to the liver for further metabolism and absorption, as well as detoxification. So here, so some of the peculiarities of portal vein you need to know. So this portal vein, it begins like the veins from the capillary plexus in the gut, and it will end like arteries by dividing into hepatic sinusoids. Okay. So in addition to this venous blood, which it drains, it also conveys the absorbed portions of the digested food. Okay. So basically I told you, nutrients it absorbs. Now this portal vein, it doesn't have valves. Okay. Neither the portal vein nor the tributaries, they do not have valves. So they are devoid of valves. Unlike other veins, these are devoid of valves. It acts as a reservoir of blood, and about 1/3 of the entire volume of blood is stored in the portal system. And two streams of the blood, they pass along this. Okay, so if you see the portal vein, two streams, one is from the splenic and one is from the superior mesenteric. Okay, they run here within this because it is formed by the union of these two veins. So out of the 1500 ml of circulating blood through the liver per minute, so about 1500 ml of blood, that is 1.5 liters of blood circulates through the liver at a given point of time in a minute, okay? So out of that, about 1200 ml is entirely provided by this portal vein, okay? And only 300 ml is contributed by the hepatic veins. So how is this portal vein formed? Portal vein is formed by the union of the superior mesenteric vein and the splenic vein. So the site is just behind the neck of the pancreas, okay? That is at the level of L2 vertebrae. So this course of this is divided into an extrahepatic part and an intrahepatic part. So the extrahepatic part, till it reaches the liver, where it divides into right and left portal vein, okay, so it measures about 8 centimeters in length and is about 2 centimeters in its width, okay. So from its formation, that is from the trunk, it passes upwards and slightly to the right behind the neck of the pancreas, as well as neck will be here, neck of the pancreas and the first part of the duodenum. Then it enters within the right free margin of the lesser omentum in front of the epiploic foramen here, and it reaches the porta hepatis where it will divide. So that is till there, it has its extrahepatic course. Okay. So the intrahepatic part, what happens is this right and left branch of the portal vein, they will enter the physiological lobes of the liver, the right and left physiological lobes of the liver. So there they will break up into the portal, that is sinusoids, hepatic sinusoids there. Okay. So that is how it happens. So from that hepatic sinusoids, what happens? Blood is drained by the central veins, and central veins go to the sublobular veins. Then they open into the hepatic veins, and hepatic veins open into the inferior vena cava. And from there, it goes to the heart. So what are its tributaries? Tributaries of portal vein. Okay, so this this was the extrahepatic course, which we divide into infraduodenal, retroduodenal, and supraduodenal, which I already told you. Okay. So the tributaries of this portal vein include formative tributaries, which are superior mesenteric vein and the splenic vein. Then we have the other tributaries, which are received by the trunk of this portal vein. So these are the right gastric. You can see okay, so the right gastric as well as the left gastric veins, okay. Then received by the two divisions. So the divisions also will receive. So that is the cystic vein as well as the paraumbilical veins, okay, paraumbilical veins and cystic vein. So the trunk also receives the superior pancreatico-duodenal vein also will join there. Okay, so either it will join the superior mesenteric or it will join. So that is the thing. Okay. So these are the tributaries of the portal vein, formative tributaries, superior mesenteric and the splenic. Then we join the trunk, that is the right and left gastric veins. Then we are joining the branches of it. Okay, so the right branch, cystic vein, left branch, we have the paraumbilical veins joining. So this is how, where it is broken down into liver sinusoids, enters the central vein to lobular veins, and it goes to the hepatic. Okay, so sublobular veins and hepatic veins. Hepatic veins, it opens into the inferior vena cava. Okay, right. So portal vein, when you write about okay. So what we mean by portal vein? What are its peculiarities? Okay, peculiarities, its formation. So we talk about peculiarities, then what area it drains, what two things it doesn't drain. Okay, it doesn't drain the rectum and the anal canal. So formative veins, and then formation where it terminates. Okay, termination. Then the parts, that is we have the extrahepatic and intrahepatic part. Okay, hepatic. Extrahepatic is again divided into infraduodenal infraduodenal, retroduodenal, and supraduodenal. Okay, so 3 parts. So those things, and then you write about the tributaries. Applied aspects. So whenever there is anastomosis between the portal system, portal veins, as well as the systemic veins, and whenever there is increased portal hypertension, it results in these anastomotic channels becoming dilated. Okay, and if it is in different size like esophagus, it will cause esophageal varices. Around the umbilicus, it will cause what we call it as caput medusae, that is the engorgement of those veins. Okay, and in the rectal part, we see the hemorrhoids, internal piles. Right, so with this, we end the class for today. So thanks for watching Auricle. For more social content, you can follow the social media handles, that is YouTube, Instagram, Facebook, and Telegram. Okay, and those who have not yet downloaded the app, you can get it on Google Play and App Store. So download the app and begin your journey with Auricle. So until next, thank you. Bye. Thanks.